Okay boys, welcome back. The issue of micturition is over, but if you have any question, confusion, anything, still, it's open. If you have anything, one question came from inhibition, okay? I remember the question, so I wanted the whole class to listen to the answer. It's not very clear that how inhibitory centers are really controlling the spinal cord, what happens at the time when we are at rest, and what happens at the time when we are in the phase of passing urine or micturition. It's a valid question, okay? Now, inhibitory centers right now, they are sending the descending fibers, and these fibers are going to the various areas of the spinal cord, okay? Now, we have different centers, as I told you, somatic center, we have parasympathetic center, and we have sympathetic center, okay? You know their functions already, what they do. Inside these centers, you have the main neurons, which are parasympathetic neurons, which are the sympathetic neurons, and which are the somatic neurons. But within these centers, majood are some special neurons called the interconnecting neurons or the interneurons. So between the somatic neurons, interneurons are present. Inter means, it's mabain actually, it's between, isn't it? Interneurons are also present in the parasympathetic. Interneurons are also present in the sympathetic. And interneurons are also present between the sympathetic and parasympathetic. And interneurons are also present between the somatic and parasympathetic. And interneurons are also present between the sympathetic and somatic. So it's a very complicated connection. It's not easy actually. Okay? Now, make it simple. Interneurons usually are of the inhibitory type, but they can be an exciting connection also. Okay? They can be excitatory or they can be inhibitory in nature. Okay? Most of the time they are inhibitory in nature. Alright? Now, if you have markers like somatic center, okay? Now think about the somatic center and think about the inhibitory center. If the inhibitory center wants to inhibit the somatic center, okay, what will it do to the direct neurons of the somatic system, and what will it do to the interneurons? It has two connections, for example, okay? So what is the message going to the somatic neurons directly? What do you think? The question is now inhibitory center is there, okay? Is the inhibitory center somehow controlling the somatic neurons or the somatic center directly, or do you think they are doing it through the indirect circuit, through the interneurons? What is your answer? Interneurons. If the interneurons are there, what kind of interneurons would be acting? Inhibitory or excitatory mainly? Inhibitory. So it means inhibitory center is inhibiting the inhibitory interneurons, isn't it? If you inhibit the inhibitory interneurons, what will happen to the somatic center? Excited. Okay? If it's excited, what will happen to your external urethral sphincter? Closed. Is it the situation now? Right? So your inhibitory center is inhibiting the inhibitory interneurons, and inhibitory interneurons are now not, obviously they are not working, so your somatic neurons are active. If they are active, what are they controlling, or what are they exerting control on? External sphincter, and that's why it is now inhibitory center. Now this is about the somatic story, okay? Now think about the story of the parasympathetic. Now what is the inhibitory influence coming on these parasympathetic center now, right now? What do you think? Inhibitory neurons or inhibitory descending fibers, what are they doing to the parasympathetic center? What is your idea? They are doing inhibition. The final result is inhibition. How are they achieving inhibition at that level? What do you think? They are stimulating the neurons, inhibitory interneurons, which are connected with the parasympathetic neurons. That's it, isn't it? So yeah, the main pathway is, now in this case they are activating the inhibitory neurons. In case of somatic center, they are inhibiting, isn't it? So did you see the role of the interneurons? interneurons are dominantly inhibitory in nature. There may be some excitatory also, I'm not saying that, but dominantly they are inhibitory in nature. You are considering the inhibitory interneurons everywhere. Okay, interconnecting neurons are usually inhibitory in nature. So in case of the somatic center, your inhibitory interneurons are inhibited. In case of your parasympathetic center, your inhibitory interneurons which are modued there, they are excited or stimulated. So they will now inhibit the parasympathetics and your parasympathetics are suppressed. But as the volume increases in the bladder, then the change in centers happen. You are shifting the inhibitory control towards the excitatory controls, and at the end the inhibitory control is taqriban switched off and excitatory control is full, and now the situation is reversed actually. Did you get that? Okay, so this is how it changes from inhibition to excitation. All right, any other question about the bladder, about any confusion or lack of understanding? No? The issue is easy actually, it's not really difficult. If you come up with any question later, we can continue, you can ask me the question. Right now, we are opening another very important issue, and that's about the concentration and dilution of the urine. Well, I actually did not bring the presentation. I was in the frame of mind that this lecture is tomorrow. So I did not send the presentation to Abdullah. We'll do it right now interactively. We'll finish it off and later I'll send you the presentation. You can read it really. Okay? Presentation only gives you a clue about the diagrams and understanding few things, but I think interactive discussion would be sufficient for us. There is no problem. Okay? But keep asking and keep responding. This is very important. Okay. Concentration and dilution. First of all, identify what I have drawn on the board. What have I drawn on the board? And I want you all with me. All of you are not with me right now. I want all of you with me. This is only I can continue with the discussion if you are with me. If you are with the mobile, then we cannot continue. Okay? Yep. Okay. The red picture, the red color. It's your identification now. I have drawn only a sketch. Identify, I have drawn two things here on the board. On the right side, the green picture, and on the left side, the red picture. First of all, tell me about the green picture. What do you see? Nephron. You're saying nephron. Salman is saying nephron. Do you agree? No. Who is not agreeing? Okay. Who disagrees? The question is, and why? This is a question. Okay? If you are challenging Salman's idea, then you have to have some answer in the mind. Why did you think that it is not a nephron? Or why is he thinking that it's a nephron? Yeah, please. Which part is missing, my dear? Glomerulus. Okay. All right. Good. Very good. Okay. Good thinking. Let's make it. But I was talking about the general situation. Was it a nephron? Yes. It was a nephron also, but you put the glomerulus also on top of it so that you have a picture, and that is good actually. Okay, I should have done it before, and let us connect with this one so that you have a better idea now. Okay, all right. Now it's very easy. I just wanted to see that are you picking it or not. So one side you have the nephron. Okay, what do you have on the other side? Okay, I want the specific answer, please. I want the specific answer. When I'm doing this, what I mean actually is that I am breaking it into the capillary plexus first. Again, it's a capillary plexus, and from that I'm getting this one, and it's going up. What have I drawn here? Okay, go one by one because I think it's some confusion going on here. What is this? Afferent? It's Okay, let me show you the direction of the blood flow so that you are pretty comfortable. Otherwise, you are getting confused with it. Okay, now what do you say? Okay, now everybody's, because you're thinking which way the blood is coming from, which is efferent, which is afferent. Okay, all right. So this is afferent, first one, and then what you have? All right. Now what will you say about this thing? Okay. Vein. Okay. 3 answers: peritubular capillary, vein, vasa recta. Pick one. Okay. Out of 3, there is one answer, definitely. Okay. Is it a peritubular capillary which is coming down there and then going up there? It's not. So keep it away. Does it look like a vein which is starting soon after? If something is following the nephron completely into the medulla and it's coming back up again in the same shape like a taweel loop, what kind of vessel is this? It's vasa recta. Thank you again. So it's vasa recta. Alright? So you have to identify, when we draw a picture like this is vasa recta, because vasa recta is going as long as you are having this loop of Henle. Peritubular capillaries are only for the cortical nephrons, and they are in the upper part actually. They are not really touching and occupying this level. Okay, this level is taqriban same here. Okay, so vasa recta. The blood is going down here and the blood is coming up here. It is the descending limb of the vasa recta, or the blood is coming down, and it is the ascending limb which is going up, vasa recta. So the blood, it's a special type of the capillary that we have. Okay, so this is about the vasa recta and the nephron. Okay. Well, vasa recta, the whole thing I've shown you open like this. Okay, but actually this whole thing is in like together. Yeah, the whole bunch is together. They're not far away from each other. Okay, they are just very tightly packed together. Everything. This thing is coming here, and this thing is coming there, and all 3 and these 2 limbs, and maybe other vasa recta also. They're together actually. So just touching each other together. But in the diagram, we saw them separately, and we show them separately because we understand the diagram, that what is it doing and what is that doing. All right. Okay, but actually they are very tight in position. Okay. What is this area? This is all interstitium. Great. Okay. It's all interstitium, all levels. Okay. In this part of the interstitium, yeah, a little above actually, a little above. This level is cortex. This is medulla. Okay, so most of your nephron part is coming, and most of your vasa recta is coming in the medulla. Okay. What kind of nephron are you looking at? Oh yes, it is a juxtamedullary nephron. Okay, it's most of the part, it is lying in the medulla, and its glomerulus is mawjood very close to the corticomedullary junction, but mawjood in the cortex. You remember that? Yes. It is mawjood in the cortex, but at the corticomedullary junction, close to that. Okay. All right. This is the deepest part of the interstitium. Okay, the deepest part. This is the upper part of the interstitium, medullary interstitium, and this is the deepest part of the, or the lower part of the medullary interstitium. Different levels. Okay. Now, look at the flow. Look at the flow of the fluid. It's flowing in this direction, right? Here. Then it's flowing in this direction. Then it's flowing in this direction, isn't it? Okay. Look at the directions. Look at the direction of the blood flow between the 2 limbs. Is it the same? I'm talking about these 2 limbs. Direction of the blood flow, is it the same? No. It's opposite, isn't it? Here, coming down and going up. Very slowly, very, very slowly. In the medulla, the blood flow is very slow, and it has a special meaning. It is required here. Look at the direction of the blood flow, fluid flow in these two limbs. Same? Not same. These two limbs, same? Not same. Okay? It's opposite. For opposite flow, we use the word counter. Counter means? Against or opposite. Okay? Current means? Flow. So instead of using opposite flow, I'm using a new term. I'm saying counter current. When I say counter current, you will understand that, oh, you are talking about the flow, two flows in opposite directions. Okay? Counter current. Do you see in the vasa recta, it is counter current phenomenon happening? Yes. Do you think in the nephron also, there is a counter current phenomenon happening? Yes. Hold it here. Okay. Let's get back. Okay? So you see this unique word, the counter current, and we will use this word here in concentration and dilution. Now, do we really pass urine sometimes which is very concentrated? Yes or no?
Yes.
Okay. What times are those when we pass concentrated urine?
After wake up.
Yeah.
In the morning.
In the morning.
After sleeping a long time.
Okay. All right. Well, if you are, no, there are two things. One is the volume of the urine, and one is really the concentration of urine. Where do you feel the urine will be more concentrated? When you wake up in the morning after regular sleep and you drink water and chai and coffee and asir, and then you go and sleep, and in the morning you wake up, will it be more volume? It will be moderately concentrated, definitely, but will it be more volume? Or okay. But in sense of true concentrated, where you feel the urine is very dark yellow in color, and it is very little in quantity, and you feel it is a like thick urine, or it's a very concentrated urine. What times are those actually? In case, yeah, when you are approaching towards dehydration, or when you are in a state of dehydration, or when you have been fasting and you have not passed urine for a long time, or when there is a takhir for many, many hours, and you didn't have the water also for a long time, and even then you are passing some urine. That urine which comes without water, relative dehydration, you will see that it is surely more darker and more heavier and more concentrated. Okay? And as you drink water more and more and more, what happens to the color of the urine? It gets diluted, the color becomes lighter, and sometimes it becomes like water. Okay? It happens, especially in winter. And if you drink a little more water, and if cold also, sometimes you pass a urine which is like watery color. Okay? Sometimes colorless urine also. It happens also. Or a very light colored urine, isn't it? That's a diluted urine. So it means our system produces concentrated urine, and our system also produces dilute urine, and the message is still not there. I talked to you, I gave the message to you, and still you don't respect for any message. I think I should stop the lecture and you do whatever you want. Is that okay?
No.
I never get angry really, okay? I only want to carry all of you with me. This is my idea, so that we are learning together. This is the only thing. If you don't want me to continue, it's up to you. As you wish. I can send you the presentation. I'll give you the attendance also. I have no problem with that one. Okay? But at least don't show disrespect to the class. I'm requesting you again. We are talking about the times, overhydration to dehydration, the intake of water, and that affects the output of the urine. The question is, why are we producing concentrated and diluted urine? What is the idea behind it? Okay, kidneys are doing it, we are producing it, we are passing it, we are seeing it, we feel it, we know it, we don't think about it. Why? What is the purpose of sometimes urine is getting concentrated, sometimes, what is the whole idea behind it? What do you want to do in the body actually by doing that? You are doing that for the sake of the body. You are doing, you are maintaining something. Now question is, what are you trying to maintain? Number one, all right?
Concentration of
concentration of solute, I am hearing two good words really here. One word is the volume. You want to keep the volume of the water inside the volume of fluid so that it should not over exceed or it should not decrease below the desired level also. Okay, so you want to avoid this. That's why kidneys are maintaining homeostasis, right? Okay. The second thing which Abdullah is saying, concentration of solutes. What do you mean by that? When you say, first of all, let's make it clear. When you say concentration of solutes, what do we mean by that? Osmolality. Okay. Great words coming up, but let's make it very clear. What is making osmolality and which osmolality are we talking about? First of all, let's focus which osmolality you are talking about. Inside the cell, outside the cell, both, or what? Basically. Outside the cell, inside the cell, both. Which case you are considering mainly?
Outside.
Outside the cell. It means you are talking about extracellular fluid osmolality?
Yes.
Or yes or no?
Yes.
Outside the cell I am saying.
Yes.
You are saying, okay? Agree?
Yes. Extracellular.
Is plasma a part of extracellular fluid?
Yes.
So are you maintaining the plasma osmolality?
Yes.
Okay, that's one thing. Okay. Who is contributing to the plasma osmolality? Sodium. Okay. Ions. Okay. And proteins.
Water.
Okay, water, because water is definitely affecting it. But if you are talking about it's the oh, that's a very good point. We are just coming to it. All right. But in terms of solutes, first we take. So you are saying ions, right? You are saying sodium. You are saying proteins. Who else? Glucose. Okay. All right. So you are saying different kinds of substances which are present in the plasma. What you mean to say is collectively, okay, different things which are present in the plasma. They are together making it. Now, okay, they are contributing to the osmolality. But we have to have a pick of one substance which is the most important for osmolality by all means, okay? Now you have got glucose, you have got proteins, you have got organics, you have got waste products, and you have got sodium, and you have got other electrolytes and so many things. Yes, now choice is yours.
One more, what is it? Creatinine?
Okay, in the group of the waste products, okay, we collectively take it. So what is your choice? Who is contributing maximally to your osmolality? When I say the word osmolality of the plasma, one thing should really spark in your mind without any doubt. And all other are like gone, no consideration at all. One thing totally supersedes others. The answer is still a mixed answer. We have to very cleanly move towards one answer. Okay? All right. Now, osmolality, let's get back. You will answer correctly. I'll further guide you to the answer. Osmolality, okay, is the concentration of solutes.
Okay.
Is osmolality depending more on the number of particles or the size of the particles?
Size.
First you define.
Size.
Osmolality. To create this concentration in one area, okay, do you need the size? Size is more important, or the number of particles? You have got different characteristics, okay? The number of particles or the size of the particles. Which one is more important? Number of the particles. Yes, it is number of the particles, please, okay? Now, if you are considering, you are not considering the size now, you are considering the number of particles, again go back to your choices, and now which one thing would you select? Who is in favor of sodium? How many are in favor of sodium? All right. Few hands only, Abhi. What about the proteins in general? Very few. What about the waste products collectively? Urea, creatinine and all those things. What about other ions which are there? What about glucose? You have to go back to your foundation concepts. It's very, very important. You are in risk actually, okay? This is at risk situation. At this point of time, when you're learning clinical so much, it's a very basic consideration that is still missing here. Without thinking, it should be a reflex of yours that you have to respond. That osmolality of your plasma depends on one and only most important thing, which is more than 90% osmolality contributor. 10% or less than 10% for all other substances. And one is 90% or more than 90%. Such an important thing. No, we are talking in terms of solutes first of all. We are not talking in terms of water. Okay? I'm saying which solute is most important out of these? This is the question. Okay? It is sodium. Come on. It is sodium. All the way. So everything depends on sodium. Please. Okay? All others on one side and why fakat sodium on one side. Imagine. Okay? And that is doing the job. 90%. So with closed eyes, even in the sleep, if I wake you up and say, this is the question, you say sodium. Like this. Okay? You should be like this. Okay? This should be your response. It is so important. Okay? Anyway. So please, plasma osmolality, sodium, and the most important function of concentration or dilution of the urine, or why kidney is doing it, just to keep the osmolality of the plasma normal. You don't want osmolality to go up, you don't want osmolality to go down. It should change in only a very narrow limit. What is the osmolality taqriban normal? We know that. It's approximately. If I give one figure to it, yeah, 290 is a good answer. From 290 you are a range, it's good. Yeah, it's about 300 or sometimes 285 to 300. But even if you say 300, Taratamiya, it's a good answer really, perfect answer. Great, okay? So this osmolality has to be maintained. You can't go below 280 or like this. You cannot go above like 304 or 5 like this, because then problems will start in the body and total homeostasis is disturbed. Okay, so this osmolality is so important to be maintained that to keep it secured, the body wants to concentrate the urine or dilute the urine all the time, depending upon how much water intake is coming, what is the situation. Okay, so intake output is very, very important. Okay, so idea is, the message is that why we are doing this, to maintain osmolality, to maintain the state of hydration properly, and that will do. Now coming to another very important point, coming to his response and one more response. If you want to change the osmolality of the plasma, okay, you want to change it. How can you change the osmolality of the plasma? You want to change it. Changing the water. You increase the water, what will happen to the osmolality? Decrease. If you decrease the water, remove the water, what will happen? Increase. This is one way. What is the other way? Sodium. Increase the solutes like sodium. Okay? If you increase the sodium, what will happen to the osmolality? Decrease. If you decrease the sodium, okay. Now compare these two ways. Which one is easier and happens most of the time in the body? That's it. Okay, so actually the operation is happening through the water. Okay, you're not adding sodium daily extra and that sodium is going in large amount and that sodium is excreted. No, sodium absorption and excretion is very well regulated actually. But if you want to change osmolality in the body, most of the time and mainly it is happening through the change in the water content. Okay, that is so easy and that is so quick and that is so manageable really, isn't it? Okay. Let's get back to this diagram. In the kidneys, we have a perfect mechanism for concentration and dilution of urine. Why? You have the answer, but this mechanism, which is operating in a normal kidney, is so powerful mechanism that this mechanism can concentrate the urine up to 4 times of the plasma osmolality. In extreme conditions, in a state of dehydration, the maximum osmolality of the urine will be 4 times that of plasma. Imagine if it is 4 times more than plasma, then what will be your osmolality at that time? It is
1,200.
1200 milliosmoles. And sometimes those persons who live in deserts, okay, nomadics here in Saudi Arabia, if the person is living totally in the desert, really, in olden days and still now, and they have scarcity of water, there is a problem, and in low water areas, their body mechanisms